Hello, my name is Dr. Ray Sterner, and I would like to introduce an approach to addressing the social determinants of health through helping stressed families by using a new and exciting form of online decision support and on-the-job training for primary care clinicians during the course of their routine well-child visits. Using this tool, you should be able to help some of your most distressed families and their at-risk children, and also learn a new clinical skill which can be recognized with MOC 4 and CME credits if needed. There are a number of AAP recommendations that address conditions that are associated with family stress and are known to be the so-called social determinants of health. These conditions are more common in poor families, but not exclusively so by any means. Some of these factors recommended by the AAP for screening and assessment that we will address include parental depression, addiction, intimate partner violence, food insecurity, and harsh punishment. Fortunately, we now have considerable evidence that one general clinical approach has been shown to have a role in improving clinical outcomes in all of these varied clinical issues. This is MI, or motivational interviewing. The approach is really quite simple in theory. It's about talking to individuals in a way that helps them explore and resolve their ambivalence about making a behavioral change, not just by giving advice, but acknowledging both the pros and cons of making that change. MI theory asserts that if the reasons for not making the change, the cons, are not fully acknowledged, then the individual's mind is not fully available to listen to the good logical reasons for committing to change. The focus is on empathic and non-judgmental communications, and there's evidence for positive behavioral change around a number of topic areas using specific techniques, including open-ended questions, asking permission to start the conversation at all, reflective and empathic listening, sharing the agenda setting, eliciting pros and cons of change, providing information using the elicit, provide, elicit technique, inquiring about the importance and confidence of making a change in a certain time in the person's life, and then summarizing the conversation. The evidence for efficacy for MI usually leans on another clinical conceptual model, the stages of change, meaning you want to talk differently to someone who has not even considered behavioral change compared to someone who has already decided to take action. So before giving advice, assess the stage of change. Yet the use of MI has not taken off in primary care. There are probably two reasons for this. One is lack of time. It takes longer than simply giving advice. And the other is training. While the outline of MI I just reviewed is all you really need to know in theory, but there is practice needed, and that often requires attending workshops and practicing some of the actual phraseology that has worked out best in difficult conversations so it rolls off your tongue easily, and perhaps maybe even more important, learning how to undo years of becoming an advice-giving machine that primary care doctors have the reputation for being. I want to now illustrate an approach to adapting MI for primary care with the help of CHADIS' implementation of a screen called the Seek, or Safe Environment for Every Kid. This was developed by Howard Dubowitz and his colleagues at University of Maryland, and it's a 14-item screen that covers food insecurity, parental depression or extreme stress, harsh punishment, intimate partner violence, and substance use. The team has assembled evidence for reducing child maltreatment outcomes when used in primary care through 2 randomized controlled trials. This presents a clinical challenge of a parent who's coming to have a well-child check and some shots, but certainly not to discuss sensitive and personal issues which the parent's likely to be ambivalent about doing. So how does CHADIS deal with this clinical challenge and the other obstacles we've talked about? Regarding the time required, CHADIS, that is, leverages time before the visit, before the face-to-face encounter, using the questionnaire of Seek, but also a questionnaire that we call now the Seek Plus that has follow-up questions that cover motivation for help if the initial screen was positive, and the impact it's having, the barriers to change or the things that may get in the way or cons, and then the readiness for change also. CHADIS also helps with time efficiency through documentation using the pre-visit data to help with documentation. And after the visit, there's individualized messaging to the care portal and handouts with even local referral information that extends what can be done during the visit. With regard to training, CHADIS focuses on the moment of care using a unique patient-specific template. That is, specific responses to questionnaire give rise to specific decision supports. One way this shows up is in the form of what we're calling teleprompters, or the kind of prompts that a president might have in giving a speech that suggests the particular phraseology that in this case is related to the motivational interview approach, and specific even to the barriers that were uncovered during the questionnaire. And there are hints on the clinician interface, and then for interested doctors, there are e-chapters, video examples, other resources, and one could even practice this approach and get MOC4 credits as another form of educating doctors. We're now going to take a tour through the parent experience. Mother of fictitious Sam Jones sees the Seek Plus questionnaire starting this way, endorses an item related to feeling stressed out, feeling depressed, and little interest and pleasure, and says that these feelings have impacted on her work and care of the home. And then when asked if she's getting help, she says, no, I'm not getting help, and no, I actually don't want help. And the main thing that's getting in the way is that I don't want to take medications that are associated with feelings of depression. A stage of change question shows that she would be willing to talk to other family members if things continued. Now we're in the clinician side, and the clinician gets this detailed report for a heads up and sees that there was a positive Seek depression score for the parents, chooses to begin the PST, gets into the PST environment, seeing some red alerts on the stress depression area. These are the items that were endorsed. There are some above the tab, there are some words that might help introduce this line of questioning. And on the right panel, you can see that there's some documentation already available. Now, clicking on the stress depression tab, there is a teleprompter that provides some guidance for beginning the conversation with the parent about their stress and depressed feelings. Clicking on the barriers tab below gives a different teleprompter, here getting to the heart of the motivational interview, where we're reflecting on the cons for change. I see not wanting to be on medication is holding you back from getting help. Empathetic statement, I understand lots of people don't want to take medications, and so on. If we've engaged the parent now, we're ready to move to the plan section, and there are some dispositions one could discuss and record by some clicks, and here are some of the hints and guidance, in this case about that cognitive behavioral therapy has evidence that makes it look like an alternative to medication, or can be used in conjunction with medication. Now we're ready to review the handouts that were assembled, and Here are some of the resources that were put together because of this the parent-endorsed depression issue. And here is an example. This is what some other handouts might look like. And now we're hitting the Care Portal tab, and there are paragraphs that have been assembled ready to go to both the Care Portal text and a printable handout. These are individualized by the doctor's name, and one could unclick the paragraphs, add your own words if you want to. And we're going to now take a look at a preview or print this handout. And now we're ready to lock the report so that we can export it to the EMR or copy paste it to the EMR or just print it out. We're going to send this report to the mother, and now Sam Jones' mother is visiting the Care Portal, sees their visit notes available, and takes a look at the headlines here and clicks through to see the handouts and Care Portal text we saw earlier. This is reminding us that the documentation has been done for the report. After the visit, this is a possible moment where a doctor might become interested in learning a little more about how to handle parental depression, and through an e-chapter, or visual learners might prefer to look at videos. And this is some content in a video. There are a number of case examples that are provided, and this is an example of the e-chapter, which is bulleted, and you can click for further information such as recent research. This slide illustrates a typical run chart as required by the specialty boards for MOC, which is provided automatically for you. And this is another view of feedback that you would have in an MOC experience, where the number of interviews documented for positive depression screens are portrayed. I want to thank you for your attention, and if you have any questions, please contact me further.